Excellent morning, everybody, and welcome to this meeting of the Board of Directors of Lincolnshire Partnership NHS Foundation Trust. My name is Kevin Lockyer. I'm the Trust Chair. As a matter of course, we start our board meetings with a staff or patient story, and we're doing that as usual this morning. We're joined by three members of staff from the Early Intervention in Psychosis service. Now, I'm going to do a quick roll call. Hopefully I'll get this right. We've got Rachel Bradley, Emma Barras and Simon Kettle, and you're all here. It's really not. It's good to have you here this morning. Welcome, and thank you very much for giving up your time to come and talk to us about what you do, and with a focus on particularly on what you do for patients. So I will hand over to you. The floor is yours.
Thank you very much, Kevin. We've got a couple of slides. Do we put them on the screen for you? Would you like to share them?
That would be fantastic. If you know how to do that, please don't ask me for technical advice because I'll just break it.
Let me see if I can do that for you. So that should have hopefully.
That's perfect. We can see that, Rachel.
Does that come up okay? Okay. Yeah. So we obviously, we're here today to talk to you. We're a county-wide multidisciplinary service with a central hub based in Lincoln. I've just briefly listed our staffing at the moment. So there's myself as the service manager, Emma as the team manager. We've got about 13 care coordinators, skill mix of RMNs, OTs, social workers, some associate practitioners, psychologists and a CBT therapist, 2 CBT therapists, peer support worker who is Simon, who's here with us today, and then we've got some admin staff. So what do we do? We're a comprehensive assessment and intensive treatment service for people aged 14 to 65 years who are experiencing a first episode psychosis or who present with an at-risk mental state of developing a first episode psychosis. We're very orientated towards recovery with an emphasis on experiences rather than diagnosis. And we focus on optimising outcomes for service users, promote awareness and understanding of psychosis. And the emphasis on that as well is on education and employment, getting people functioning back into their community, living their best lives. Treatment is provided in the least restrictive and stigmatising setting. The next slide looks a bit confusing. I'm not going to go into this in a lot of detail, but it just kind of gives you our pathway. So from referral, we have a 2-week referral to treatment window. So it's quite a rapid service. We pick people up very quickly, do a full comprehensive assessment. The standard is that all 60% of people are assessed within 2 weeks, and we do achieve that. A NICE approved care package is then implemented once they go into treatment. And that's NICE concordant care, which involves CBT, cognitive behavioural therapy for psychosis. So our therapists are specifically trained to work with people with psychosis. Behavioural family interventions, looking at medication, including clozapine, antipsychotics. Education employment is really important. We're linking with the IPS workers. Career focused education and support, wellbeing support and physical health assessments as well. And I'm going to hand over to staff because that's why we're here today. So we've got Emma Barras, who is our team manager, and Simon Robertson, who couldn't be with us today, but Simon Kettle, our peer support worker, is with us.
I don't know, do you want me to go first or do you want to go first? Do you want me to go first? Okay. So I've worked with with the IP since 2012, really, when it was originally STEP, and then when we were integrated into CMHTs, and then when we came back around as EIP. Have been a team manager since 2017. Really proud of the team. I think definitely we keep patients and carers at the focus of everything. Definitely at the moment the challenges have been, we've seen a lot of increase in referrals. It's been more difficult really with the referrals and managing that. especially because of the CALMs that we have to use as the assessment tool. Everyone has to be HE trained, which makes that quite difficult if people are coming into the team as the training's not readily available. But yeah, really proud of the team, and I think we're doing really well. Don't know if I need anything else. I do want to hand over to Simon about how you find it working with us, Simon.
Hello, good morning to everybody. It's very nerve-wracking to be here, but very nice to be here in my front bedroom while you guys are all wherever you guys are. Yeah, I'm the peer support worker at the moment, the only peer support worker for early intervention in psychosis service, and I've been doing it since 2018. I started in June 2018. And I guess, as you probably know, peer support workers have got lived experience, and I have lived experience and have unfortunately been in acute wards for a couple of sessions very recently. If you'd asked me what working for the early intervention in psychosis service was like 5-6 years ago, I would have said I haven't got a clue, because I was a painter and decorator. So I had no idea what mental health was until it happened to me, and I was psychotic, and I went into A&E Grimsby and said I was a terrorist. So my experience is quite strange, I suppose, but very the team that I'm working for is absolutely fantastic. It looks after me really well. It looks after all its service users really well, and makes a massive difference to people's lives, and changes their perceptions. The interventions that all the clinical guys do is absolutely fantastic, and it works really well. And I'm really proud to be part of the service, and I hope that the service will grow and expand and be bigger and better and stronger and more able to cope with what's thrown at it through the pandemic that we're still suffering with. So yeah, I've really enjoyed being able to come and speak to you guys today. I know it seems to be only a one-to-one thing, and I appreciate that. So thank you very much for your time.
Thank you. And just a little bit about why we do what we do. So psychosis is one of the most serious mental health difficulties. It's very frightening and confusing as an experience for the person. It can be very bewildering, also very frightening for the families. Research indicates shorter durations of untreated psychosis are associated with better responses to treatment, and it increases the likelihood of a good recovery. And just a little bit in terms of feedback and things that our patients and service users, carers tell us about the service, in terms of the positive impact and what we're doing in terms of helping people live their best lives and be members of the community as well. Thank you. Any questions?
Thank you very much, Rachel. So I'll open to board colleagues for questions. Sharon.
Yes, thank you. Simon, I just wanted to ask, with you having ongoing mental health issues and managing this role, I'm guessing you feel quite supported in the team, but I'd like to explore whether you feel supported and what the organisation can do for peer workers to enable them to do the role.
I think there's a lot going on within the organisation, with Sarah Bruins looking after delivering more stuff for peer support workers, and so we've got the code of conduct, and we've got packs for people coming into the new posts that are being produced. So there's a lot of things going on that Sarah Bruin's doing, and I've been part of the focus group that's been putting it all together, so that we are feeling more supported in terms of recruitment. And when we first join in post, and there is the proposal is that we'll get more sort of senior peer support workers, and there are a couple already in post, one in the recovery college, and hopefully the training will become in-house, so to speak, rather than outside, because it's important to be trained, but it's also important to realise that the peer support worker has got experience, and lots of different types of experience, of course, because we all have lots of different types of experience, don't we? And sometimes it gels really well, and I think that helps me certainly, and my experience of psychosis helps me deliver support to my service users that I see on a regular basis. That helps.
Yes, lovely. Thanks, Simon.
Thank you, Sharon. I've got Chris next.
Yeah, thanks everybody. Chris Higgins, I think you know me, Director of Operations. Thanks for the talk this morning. Just curious, really. I mean, I think as an organisation, we're putting greater and greater kind of emphasis on carer family involvement and how we can get that right. I think particularly for first onset psychosis, it's one of those areas where family involvement's probably more important, or one of the most important areas to get everybody in the family understanding what's going on. Just wondering how that works, and whether you've got the resources you need and to kind of make best for everybody in that situation.
Yeah, do you want me to answer that, Rachel?
Yeah.
So part of our NICE recommended interventions, one of the outcomes is carers. So the main focus is carers. All the team are trained in behavioural family therapy. That has been challenging to implement that. It's been quite challenging to recruit families. I think it's been, we've been looking at how we adapt really and sell it to families, because I think if you're going saying behavioural family therapy, sometimes, you know, the wording. And also logistically, being a county-wide service, normally it's 2 staff members. So what we've done as well is initially it was just a care coordinators trained up, but we've trained in-house peer support workers, associate practitioners, so we can resource them as well. We've got carers packs. We use the associate practitioners as carers leads to develop the packs. We involve family from the start, check in. If family need some support, we'll do sessions with them as well. So yeah, carers is a huge focus within the team.
Brilliant, thank you, that's really good. Sarah, I don't know if you just wanted to come in now.
Thank you. I think we've lost Kevin for some reason, so well, thank you for joining us, Rachel, Simon and Emma. I think I've got sort of 2 questions. So one of them I think is more to Rachel and one more to sort of Simon and Emma, I think. So for me, like early intervention, it seems really sort of formulaic, and the performance management is really stringent, isn't it? And I didn't know whether you've got any sort of frustrations in terms of if you had a bit of wriggle room around that very sort of set formula, if there was something in terms of any innovation that you think would make the model more successful, or, you know, if you had a bit of wriggle room around it, if that makes sense.
Yeah, you're right, Sarah. It is very, you know, we're very tight with our kind of, you know, 2-week waits and things that we're given. So the wiggle room around that, there isn't much, to be honest. I think what we try to do is we don't focus on that when we're seeing our patients and carers. So for them, that's not really important, and that's not something we try and do. It is difficult because we're a county-wide service at the moment, and we're trying to deliver that within all them kind of bits county-wide. We're currently looking with Steve Skinner, the service development lead, about how we do that. So whether we move to, because at the moment we've got a bit of a hub and spoke model. So the central hub in Lincoln and our care coordinators and staff work in different localities. So we're looking to move at patches. So we'd have an east, west, south split. So we'd have little sole teams within each patch who could pick up and work more locally with people and be more readily available within them localities to hit them sort of targets and things as well. And looking at how we innovate that in terms of bringing new roles into the team. So it's not always about having care coordinators, qualified staff, you know, especially in terms of delivering psychological interventions. We're looking at the role of, for example, mental health wellbeing practitioners now, which HEE have started to roll out. So again, they can deliver things, you know, very low level behavioural activation, looking at how we can innovate the service with those sorts of roles, and even kind of upskilling and our staff such as Simon in the peer support worker role.
Absolutely.
To move forward and carry out some of these interventions. People see things like CBTP, psychosis, and think that's got to be one of the band 7 CBT therapists, and it's not the case. So we need to kind of think outside the box a bit with the staff and the resources that we've got, and use them to the full potential, really maximise the talent we've got in the team, and really upskill it as well.
Brilliant, thank you. And if I just may, I didn't know whether Emma and Simon, you've got any reflections on sort of COVID and any positive outcomes from the bleakness that we faced. Is there any positive in terms of the team working that's come from that, if that's okay?
Have you got any thoughts, Simon? Do you want me to let you go first?
Oh, well, yeah, I don't mind. Yeah, I'll go first. Yeah, I think the things that have been good in terms of what's happened with the pandemic is that Teams, for example, what we're doing now has taken off massively in a very short amount of time, and that means that we can sort of network together quite quickly and within scope, and it's very easy to do. But obviously the downside of that is it's not the same as all being in a room and having a conversation with people, and that's the difficulty I certainly find, because I'm not technologically advanced enough to know how it works best, but I do sort of try and get along with it, but I have to be honest and say I'm a bit old-fashioned, and I have to be in a conversation space with people, and I'm happy enough to do that, but obviously we can't do that quite so readily as we used to. Hopefully things will improve and we'll go back to a different type of, maybe some sort of hybrid, so that we do this and do face-to-face as well in the usual manner, hopefully.
Yeah, and I think just reflecting what Simon said as well, the benefits of being able to use Teams with patients and giving patients the option as well of another way of really having that appointment. And I do think as a team, I think we've, even though it's been difficult and there's been a lot of stresses, we've all really stuck together and worked well together, even though it has been really difficult not being able to be face to face and be together in a room. We've all really kept quite connected and supported each other, so that's been really positive as well.
Brilliant, thank you very much. Thank you.
Sarah, thank you very much for stepping into the breach. Then I don't know where you've got to, so probably the sensible thing for you to do would be for you to continue to lead this conversation until we're done, and then I'll take over when we start the agenda proper, because I've got no way of knowing who's asked questions and who hasn't.
Thank you. It was Anita next.
And just apologies, Rachel and colleagues, my Teams failed, so I had to reboot it. Apologies for that.
So we all have technology issues, don't we?
Yeah, you have my sympathy, Simon.
Anita.
Right, thank you. I'm still reeling from the fact, Emma, you've been there since 2012. Where on earth has that gone? And I think I've got two parts to this, but one of mine kind of leads on from one of the questions that Chris asked about the kind of the involvement of carers and listening to your response, and how sometimes it's quite difficult to get them to the table. You know, and it is so important. I mean, I many moons ago kind of led the assertive outreach team, and kind of having the carers involved was so important. Now, we obviously have Simon here as a peer support worker, but I wonder if there's some, I'm now the executive lead for carers, and I wonder if there's some work we could do potentially about looking at carers, peer support workers. So actually carers are reaching out to carers. Do you think there's something in that? You know, obviously Simon does a lot of the patient stuff, and that's brilliant, but it might be, you know, people that have, is that worth something that we should look at? If I put Donna in touch with you, I know Donna has for some time kind of thought about carer peer support workers, and it sounds like your team potentially could be ripe for that.
Yeah, I completely agree. And if you look at our CCQI standards as well, just aside from that, that is one of the emphases on it, of having that carer lived experience. So definitely that would be fantastic to have in the team.
Right, that's brilliant. I'll take that as a way, as an action for myself. And I'm conscious there's loads of people that got questions behind me, so I won't kind of take any more time, but I'll touch base with you, Emma and Rachel, and we'll have a look at that. That's brilliant. Thank you.
Thank you.
Thank you. We've got Tim next.
Thanks, Sarah. Hi. So I'm Tim Harry. I'm a new non-exec director, and I haven't worked in mental health before, so you're going to have to excuse. I've got a really ignorant question I'm going to ask in a minute, but the first question really was to get a sense of the number of referrals that you've had, and you mentioned there's been an increase in referrals, and I just wondered what the sort of delta was around that. So that was my first question.
Yeah, it's around double. So for example, I think was it November last sort of 2021, I think no 2020 we sort of had 19 referrals, and I think in November this just gone, I think we had 49. So sometimes it's over doubled at some point. Some months even out the same as maybe the previous year, but a lot of the months we're looking at double. Yeah.
God, yeah. That's a real, sounds like a real challenge to go from one level to that sort of level. So how do you sort of cope with that sort of capacity increase in requirement?
It's definitely been challenging to say the least. I think especially at the moment, if we're honest, we've had a lot of vacant posts. So out of the 13 care coordinators, we've got eight. We're sort of 8 vacant at the moment, aren't we, Rachel? It definitely has been challenging. And I think again, looking at the resources in the team, how we can utilise other resources like the associate practitioners or even the CBT therapists, so asking them maybe to do screenings, etc. So just looking at what resources we can to manage the service the best we can. I don't know if you've got anything else, Rachel.
No, we in terms of caseload, we're currently holding around 226 on the caseload, which is quite a sizable caseload really for a county-wide team. I guess in terms of looking at the reasons for the increase in referrals, one of the potentials is the ARMS pathway, which is the at-risk mental state. So I think what people are doing now is recognising quite early on if people are presenting with symptoms suggestive of a psychotic illness, they're referring much earlier, which is great because that's what we want. We want that wider education and awareness, and obviously what we're doing in terms of education is getting out there because we're getting the referrals, but then obviously that's whoosh with the team and thinking, oh god, okay, but so that's one of the potentials as well. Or it could just be that we just happen to have a lot more poorly people out there at the moment. And one of the things we're doing moving forward is looking at themes and trends and why we're getting the referrals we're getting, and whether they're coming from particular localities and areas, and whether there's particular targeted work we need to do in a certain part of the county. So we're trying to look at that moving forward and look at how we deliver services.
Yeah, there's definitely been an increase from ward referrals, as you're saying, Rachel, and people becoming more, at the point of being acutely unwell. We're definitely seeing a big increase in referrals from the wards.
Yeah. Thank you.
So
can I ask a second question? This is my ignorant bit, sorry. So what really came over to me was the importance of the clue's in the name, isn't it? Early intervention and therefore better recovery and better success long term. But and it's such a broad range of interventions, but I just wondered, and I think it probably there's a hint from what you said about with the number of caseloads that you got. So you do that sort of 2-week initial assessment, so that's really quick and broad range of interventions to pick up. But how long then do you stay with individuals typically, and where do you sort of hand over?
Okay, so the at-risk mental state pathways for up to 2 years, and the first episode psychosis pathways up to 3 years. It doesn't necessarily mean we have to stay involved that long. If I guess they're stable and they feel they've done all the work that's required with us, they can go on a fast track for that period, and then if they deteriorate, there's a rapid access again back to us. And I guess at the end of pathway, it's looking at is there anything else that they require? Do they need maybe referring over to CMHT or some of the other teams, or are they stable and don't need any support from mental health services again? Yeah.
Brilliant. Thank you very, very much indeed. Thank you.
Thank you. We've got a few more questions. So Di, please, next.
Thanks, Sarah. Thanks, Emma, Simon and Rachel. I'm Di Bailey. I'm also one of the non-exec directors, and I guess my question follows on a little bit from Tim's really. So you talked about, needing seeing people within 2 weeks of referral for that assessment, and it's obvious from the comments that you showed in the little bubbles that obviously from a service user and carer satisfaction perspective, people are very pleased and appreciative of the service that they're getting. I guess what I'm interested in are what outcomes do you measure along the way in terms of, as you say, knowing when, you know, when somebody has, you know, has moved on, improved. So, you know, do you use particular outcome tools, and what sorts of things do you look at?
Yeah, we have. So part as well of the NICE standards is we have what we call the QPR and the dialogue recovery tools, and the HONUS as well. We're asking you to HONUS.
Right. Okay.
And what we've done, they're done 6 monthly, and also okay. What we've done is worked with informatics. So now they're on Rio, and we can put them on electronically. And also what Rio informatics have worked with us is that we can graph it, so we can show the patient their journey and their recovery scores as they go through that pathway and the improvements. So they've got a visual as well that we can take to them.
I mean, I think that's really important, and I think you know, the evidence base supports that. And I guess I'm interested from Simon's perspective then, in terms of working in that peer support space. Does that help you, Simon, in terms of talking about your own journey and how your outcomes changed?
Yes, massively. It helps me so much to be able to talk about not just my lived experience, but the service users' lived experience, and having a conversation about what it was like, for example, being on Ward 12 and how difficult it can be at times, and being able to share stories with each other is really cathartic for me, and helps me, yeah, massively. And I think it helps the service user as well. Yeah.
Okay, thanks very much, that's really helpful.
Thank you. I'll hand back over to Kevin just to sum up the session, but just a massive thank you again for joining us this morning. Thank you.
Thank you, Sarah, and thanks again for stepping into the breach. I'm limited in my ability to summarise the session, having missed a big chunk of it. And Rachel, Emma and Simon, I'm really sorry that happened, but thank you very much for coming this morning and sharing your story. In return for me missing a chunk of it, then I will come and see you, if I may, and you can talk when we can, and we'll talk face to face about it. And I'd particularly be interested in meeting you, Simon. I'm really the use of peer supporters is a particular you know, interest of mine, and I'd really like to learn more about your personal story and about how we've supported you to fulfil the role that you do, which is critically important. And thank you very much for doing what you do. It is really deeply appreciated. And Rachel and Emma, thank you very much too, and thank you for you know, describing your service in such detail this morning and talking us through what you do and the pressures and the challenges. Thank you.
Thank you very much for having us. Thank you.
Thank you very much. It was a pleasure. Thank you. Bye.
Great stuff. Let's move on then to the substantive agenda. We don't have, I don't think, any apologies for absence.
Kevin, just to say, Di does need to step out for about half an hour.
I'm aware of that, Peter. Thank you. Declarations of interest are, I think, as previously recorded. Has anybody got anything that they want to update or change or record for the purposes just of this meeting? It would appear not. So we'll move on to the minutes of the last meeting on the 2nd of December. Does anybody have any comments on points of accuracy or matters arising from those minutes? Jane, that's an actual hand up there. Excellent.
I'm really sorry, I've lost the functionality of the chat briefly. Hello everyone, Jane Marshall, Director of Strategy and People. I just had a point of accuracy on page 16, if I may, Chair. We speak under the IPR section as having the vacancy pipeline work as part of the board development session. That was accurate at the time, but we then subsequently changed that because of Omicron pressures to a separate board session, which wasn't an official board development session. So just as a point of accuracy, that changed, so that if we ever have to come back to that, we've got it recorded.
That's really helpful, Jane. I think we keep the minutes as they are, Peter, but we add it as Peter suggested, adding it as a matter arising. I think that's probably right, or a post-meeting note, or however we do it. But
thank you,
Jane. If there are no other points of accuracy, are colleagues content for me to sign them as true record? Please shout if you're not. Yep, thank you very much. So we'll move on then to the schedule of actions. There are 2, I think, actions that are still in progress. And a number of actions that have either been completed or closed. Do colleagues have any questions or comments on the outstanding actions, which otherwise seem to me to be self-explanatory? No, I'll take it there are none. So we'll move on then. It's a fairly momentous meeting because I produced my first written report. Hopefully it speaks for itself, but very happy to take any questions or comments on what I've written. Otherwise, I'll take it as read. Thank you. And we'll move on then to the Chief Executive's report. Sarah, you've got rather more to say than me.
Thank you, Kevin. Thank you. Sarah Connery, Chief Executive here at the Trust. So just builds on Kevin's report really in terms of if this is a slimline report, given the operational pressures that we face. We're trying to step down as much non-essential governance as possible to be able to focus energies on the level 4 incident response. You'll see in the COVID-19 section there that the Omicron COVID variant at the time of writing the report, and as I sit here today, continues to provide significant challenges to keeping the services of the Trust running. We've seen unprecedented numbers of staff having to isolate because of either positive infection or close contacts from COVID-19, more so than in previous waves. And I want to use the word prolonged because just as it seems to sort of wane slightly, infection rates start to pick up again. So we monitor it on a daily basis. I want to say a massive thank you to all services for flexibility and innovation in making sure that we can keep services running safely. And also to services who are being redeployed, staff who are being redeployed. And this isn't just within clinical operational services, but corporate teams as well. So we're extremely grateful for everything that's being done. As I sit here today, we've got 4 outbreaks, which is causing pressure on flow as well. And we'll come on to it in more detail in terms of the integrated performance report, where the prolonged absence is having an impact on our ability to achieve our performance targets. So in terms of moving on, in terms of the national position, the system continues to progress with its integrated care system readiness to operate, and in particular recruiting to key point posts on integrated care boards. Just to reiterate that the deadline from sort of go live in our integrated care system was 1st of April. Because of delays on the health and care bill going through, this has now been delayed to the 1st of July 2022, which does give us extra time to work through the detail, the recruitment, and also making sure that the infrastructure and governance is in place. I did also just want to say it is referenced in the paper about mandatory COVID-19 vaccinations for staff who are in scope. So on the 14th of December, Parliament did approve the Department of Health and Social Care decision to amend the Health and Social Care Act 2008, which means that frontline workers and those in non-clinical roles who may have direct face-to-face contact will be required by law to have received 2 doses of the vaccination by the 1st of April. A key date for us is the 3rd of February, which is the last date that people can have had their first injection of the vaccination in order to be able to meet that 31st of March deadline. The executive team have worked their way through 3 equality impact assessments of this mandate. 1 for currently employed staff, 1 for other workers, for example, agency, bank and students, and 1 for the actual recruitment process itself. So we're trying to be as thorough as we can and as fair and equitable as we can in terms of that approach. This is a really, really tricky situation. We have received guidance from NHSEI, which we work through. This doesn't answer all of the questions as to whether a member of staff is in scope or out of scope. So we're trying to make sure that we're consistent and fair. We continue to have supportive conversations with all of our staff who are vaccine hesitant for whatever reason, and try and just make sure that people are supported in their decision making, because for some this is a really difficult decision. At the time of writing the report, we've got 2,612 staff and 2,477 of them were fully vaccinated. There are reasons for people not to have had their vaccination, for example, medical exemption. They may be pregnant and wanting to have the vaccine postpartum. I just want to say a big thank you to the people team, not just in the trust, but also in the system. There is a lot of heavy lifting that's going on to make sure that we get this right, in line with our values in a supportive way. So a big thank you. There is a lot of work going on here. In terms of Lincolnshire, just a piece of good news really, in terms of our vaccination programme, that we have had over 80% of the eligible population have their booster vaccination by the end of the calendar year 2021, which compared very favourably to the national average of 64%. So a great piece of system working. Also, as a positive, we have released stakeholder briefings about our mental health urgent assessment centre, which opened this week. So it's a bit of a phased opening, but this is a really exciting development to us in terms of giving patients a much better experience in terms of when they are presenting in crisis. A&E does not always provide the sort of calming therapeutic environment that you want to find yourselves in when you're in crisis. So we'll be monitoring the impact very closely. We are using Winter Precious money to be able to open the unit, but we would look to make this sustainable in the future, should it be a success following a service evaluation. There's some points there around celebrating success for our children and young people services, and also a really good outcome for our individual placement service fidelity review, which continues to achieve a good. I just wanted to end on a positive as well. International recruitment. I had the pleasure of meeting our 2 new nursing recruits. We're starting to welcome these people, get them settled into Lincolnshire life. They were talking to me about the challenging exams that they're having to pass in order to practice in the country. The cold weather, they're missing their families. We're doing as much as we can to wrap around and offer that pastoral support to make sure that people are settled in well. Also, we were pleased to welcome a new clinical psychologist. I also had the pleasure of meeting her from Greece into our adult eating disorder service. So just want to say a big welcome to all of our international recruits. So just to sum up, it remains challenging, and just at the point that we think we can take a breath, then we're sort of faced with rising infection rates again. So we need to remain really vigilant in terms of COVID-19 infection rates. This isn't going away, but just want to end again with saying thank you to all of our staff for their just resilience and innovation and hard work. So thank you, and I'll shut up there.
That's great. That's good. Thank you very much, Sarah. I mean, a really comprehensive report, and you know, just to repeat some of the things that I said in my report to the board, in very challenging circumstances, and the fact that staff are holding up services in the circumstances is hugely creditable and admirable. Questions and comments. Question from Tim.
Hi, so Tim Harry, non-exec director. Hi Sarah, yeah, as ever, thanks very much for the report. Really really informative and helpful, and you really have my empathy around the mandatory vaccine approach, and quite rightly how it's being handled. My question is on, as you said, a very exciting bit around the urgent assessment centres, and I think there was a bit of an update this morning because it's gone live this month, hasn't it? My question is around on the urgent assessment centre in A&E when it is opened up to public walk-ins, which I think is what it said, because at the moment it's for specific services, and also around cafes. How are these sort of being or going to be advertised, inverted commas, so that people are aware of the availability of these services?
Yeah, I'll come in on the advertising of what's available, and then Chris, maybe I'll invite Chris to come in terms of the pipeline in terms of go live, because we are sort of steady as we go into given everything that we've talked about in terms of the operational pressures instead. So in terms of, we work very closely with our Lincolnshire County Council colleagues in terms of Connector Support, which is a website that's available. It covers all support available in Lincolnshire, and we really push it as well with our district council colleagues as well in terms of that as a resource that people can go to see what support is out there. We're also really pushing it through our community transformation programme. So we have invested in communications and engagement resource, working really closely with our voluntary sector and other partners as well to make sure that we're pushing out there. And thirdly, we've used some of that hospital discharge funding, that winter pressures money, to invest in media campaigns and communications to make sure that we're pushing it out there. And as Joe's put in the chat there, the crisis cafes have been on Radio Links and Look North this week as well. So we are trying to come at it from lots of different angles. But I'll hand over to Chris to talk through the pipeline for the assessment centre, if that's okay. Thank you, Chris.
Yep, no problem. Yeah, good question. So, yeah, Chris Higgins, Director of Operations. I think, well, in one breath, one take, we'd like to get to walk-ins as quickly as possible. The cautiousness is just we want it to be a success, and we don't want it to get overwhelmed. And at the moment, we've done quite a bit of modelling work around how many people will be in A&E, for example, that we could divert around, how many ambulance conveyances we could take directly, because we've got data on that. What we haven't got data is when we open the door, how many people will come in. And so the first bit is to really stress test the model of working, see what happens in terms of demand. It's not a huge unit, and if we're able to cope with a number of people coming through for that first phases, then we probably could quite quickly move into opening it up more widely. But we just really need to stress test it at this early stage. In terms of advertising that out, I think one of the key bits will be probably a bit of a soft launch as we go. If we just do a big bang and then again we just want to just avoid the service getting overwhelmed and then it not working and putting people at risk. So it'll be a steady launch, but just to kind of emphasise some bits that Sarah said there, it's part of an acute kind of, well, a crisis pathway. So it's making sure we've got those other alternatives in place in people's communities, the crisis cafes and other alternative options, so that people are supported there around their own communities and only need to come to the assessment centre when it's really an urgent need.
Brilliant, thanks very much. It'd be really interesting to see how this goes over time. Thank you very much indeed.
Thanks, Tim. I don't see any other questions and comments. Andy's commented in chat about minuting the board's thanks and support for the efforts of staff, and I think that's absolutely right, and we'll make sure that we minute that appropriately. A couple of questions from me, Sarah, if I may. The first is on mandatory vaccinations. Notwithstanding the fact that as a trust the impact on us in terms of the number of unvaccinated staff is relatively small compared to other trusts that I'm aware of, I think we need to come back to this as a board, don't we, so that we understand what the impact is if we get to whatever the date is in February and we still have staff that are unvaccinated. We as a board need to understand what's going to happen to those staff, not as individuals, but in principle, and whether or not that has any impact on services or elsewhere in the trust. So can we please have a report to board on that as soon as we're able to do it?
Yeah, can I come in on that point, because I think there is a point of governance here as well, Kevin, in terms of the decision-making process. So we won't be requesting the board to make decisions on individual cases, but what I think we need to have is the board sign off of the principles and the framework that we've used to apply to those individual cases as part
of that. And that's kind of what I had in mind. You just
and it's going to be an interesting one where, as the clock ticks over from the we won't actually know where we land until potentially, in terms of the data flow, sort of 2 days after the 3rd of Feb.
Yes.
And there is something about some members of staff holding the line in terms of potentially expecting a U-turn from the government. So each day counts, I suppose, from this point of view. So we need to make sure that we've got a firm view of the actual numbers. But absolutely, this, and every time we introduce a new service or a new role, we'll have to go around the loop again. So this isn't going away on the 31st of March. So
no, okay,
thank you.
So I think there are two actions there then, Sarah. The first is ensuring that the board signs off on a general set of principles about how we manage it, and then the second is to make sure that we're focused on any risk that flows from the fact, although 40 staff is a relatively small number, if they're 40 staff all in one place, then that changes the risk profile significantly. So we need to be cited on that and to understand that as well. Thank you. And my second point was about the Urgent Assessment Centre, and it's really to Chris, if I may, and that is that you say it's a very small unit. What have we done in terms of creating the right physical environment for it, and have we had funding not only to employ the staff to do it, but to create an appropriate environment in which to deliver the service? And I echo Tim's points about how welcome this is and how it could, it's potentially a significant game changer in terms of diverting people out of A&E. But I haven't seen it, so I want to be sure that we're delivering the service in an appropriate physical environment as well, Chris. So your comments would be really welcome.
Yeah, thank you, Kevin. So absolutely, I think in terms of scale of the project, it's that balance between pace. It was only a concept about 3 months ago, and so it's to get the work done, and I know hats off to our estates and facilities teams that come together to make that happen in such a short space of time. I think we had the companies building doors and things to make this happen over Christmas, so it's been a real kind of team effort. I'm confident in the space of absolute high quality. I mean, if you go down, you'll see that it's a real high spec in terms of what we've done. It's linked to our clinical decisions unit, and so we've got a good working space, and based on our understanding the data, we've got enough capacity to meet demand. As I say, it's the unknown element of opening to the public that's the real kind of conundrum at the minute, because currently huge volumes of people thankfully don't turn up at A&E, but would more people to attend to a specialist mental health assessment centre? That's an unknown, but we've got the right facility for what we need right now. There is options that we could use other space in the building if necessary, and I think we'll just have to kind of see how that goes and kind of monitor the situation. But yeah, I mean, if you pop along at some point, you'll see that it's a high spec and a really good environment to work in.
Excellent, thank you, Chris. I was sure you'd tell me that, and in normal circumstances I'd have gone and had a look much more easily than we can, in the circumstances in which we're working, but I will get there. And I just want to record, for the record, my admiration of the fact that we've gone from a standing start to delivering this service in a remarkably short time, both in terms of, planning and delivery. That's extraordinarily good work. So thank you very much to you and everyone that's been involved in it. If there are no other questions or comments for Sarah, we'll move on then to item 3 and risk. Anita.
Hello, I'm Anita Lewin. I'm the Director of Nursing AHPs and Quality here at the organisation. So I am here to present the risk register. I would like to start by apologising both to yourself, Kevin, and to Andy Spring. We had arranged that we would meet up prior to board today to go through the actual physical presentation of the risk register, and if we have that right. Unfortunately, Omicron has taken me a little bit left field, so I haven't had the capacity to do that. But we have got a session in with Mark Housel as well prior to the next board. So hopefully by March board, we will be looking at some of those concerns about the presentation that were raised last time. In terms of key kind of changes on the risk register currently, we haven't had it added any new risks. We have, as you've heard, already spoken about the mandatory vaccinations, and we are just working through with those principles and then deciding if this is something that we need to put onto our risk register. But at this moment in time, we have no new risks that have been added, and we have had one risk closed. And you heard Sarah in her presentation talk about the psychologist that has come over from Greece. So we are really lucky that we've managed to close that one down. In terms of some changes, the risk level around nursing vacancies, the risk level is reduced. Now, whilst it is still a key risk for us, there has been a huge amount of work done both within operational services and by the people team and members of my team to kind of support recruitment, including the international recruits that we've heard about and other pieces of work. So there's lots going on. It is still a risk, but we have reduced that risk level. And risk 155, you've heard of, and that has increased the risk with that. And we heard it this morning from the EIP team, and that focuses on the demand across numerous services. That isn't kind of exclusive. The story we heard from EIP is not exclusive to EIP. That is something that we're seeing reflective across all of most of the services that we're delivering within LPFT. So they're the key headlines from the report. I'm quite happy to kind of either pass over to risk leads if there's anything particular, or to take any questions. But as I say, the work around the presentation will be completed by March board, and I apologise, but it's been a little bit busy.
Yeah, thank you, Anita. We'll go straight to questions. First of all, though, there is absolutely no need to apologise. You know, we do completely understand that you've had one or two other things to worry about. So please don't be concerned about that. I've got an observation on a point of detail, Anita, okay. and it is partly related to presentation. But risk 155. I'm sure it's absolutely right that the risk score is increased, but there's nothing in the kind of narrative on the actual risk register that kind of speaks to why. And I think that's just an issue about rounding out that explanation so that there's a direct link through from the decision to upgrade the risk and the story in the register so that the two line up. But that's a very, very detailed point, and I apologise for getting down in the weeds, as it were.
Yeah, that's fine.
I'm not seeing any questions or comments from others. No, look forward to having the conversation then with you and Mark and Andy about presentation. I think, you know, in terms of, from my perspective, in terms of the focus, you know, the risks are right. We're focusing on the right things. There's a really comprehensive narrative around all this. But, you know, as we've recognised before, we can just sharpen up the presentation of it a little bit.
Brilliant.
Good. Thank you very much. Let's move on then to item 4, item 4.1, Ananta, which I think you're speaking to.
Yes, I'm really sorry. I'm having some trouble with my emails, but I do have the paper in front of me, so that's okay. My Teams and emails are a bit wobbly. So I don't know whether you can all see me and hear me. I'm Ananta Dave. I'm
it's absolutely fine, Ananta.
LPFT, and this is the Guardian of Safe Working paper. Is that right?
Correct.
Yeah. So the Guardian of Safe Working, as the paper suggests, is a role in our trust where we have an appointment there to ensure that all the trainees, the medical trainees who are posted to the trust, are looked after in the right way, have got their terms and conditions and their job contracts fulfilled in the right way so that they're supportive, and that if there are any concerns raised, that there is a mechanism through exception reporting which goes to the Guardian of Safe Working in the trust and that we monitor that every quarter to ensure that things are in place to address any concerns and to identify where things are going well. So the report, which I will take as read, talks about the number of trainees we have in the organization, whether they are foundation year trainees, FYs, GP trainees, which we call the GP VTS, the GP vocational training scheme, the core trainees who are in the early stages of their psychiatric training, and specialist trainees who are at the later stages of their psychiatric training before becoming consultants. So it talks about the distribution of trainees across these various groups and the gaps and some of the issues that have been raised through exception reporting, which have all been resolved. And in the vast majority of cases, as the paper shows, the current arrangements are working well. The trainees have got access to the Guardian of Safe Working. We have a junior doctors forum where these issues are discussed regularly and which I attend regularly. And we have not been fined this quarter. And on the whole, we have a robust, stable mechanism for ensuring the well-being of trainees and a good training experience. Very happy to take any questions or clarify any issues. Thank you.
Thank you, Ananta. That's a self-explanatory and helpful report. I'm grateful. Questions or comments from colleagues? I don't see any. So the board's asked to receive the report, so we've received it. Thank you very much, Ananta. I think we stay with you for item 4.2.
Yes, the Learning from Deaths report.
Correct.
And once again, happy to take questions. I will take the report as read. For people who've been seeing this report of the last several months, you will see that the format is slightly different. And as has been mentioned in several places in the report, we now have a new Learning from Deaths lead, and we have taken this as an opportunity based on her starting, as well as the feedback we've received in the past and the questions that have arisen regarding the kind of data that we want to capture. So we see this as an opportunity to review what kind of data is presented through the board report, what would board members like to see, but also the information that we do want to provide around serious incidents which are related to deaths and how they're investigated and the learning that's coming out of those incidents, as well as those deaths which are not deemed to be a serious incident or which do not go through the learning disabilities review, the leader review route. We do review them as part of what was traditionally called the Structured Judgment Review, or SJR, and in this paper has been referred to as the Mortality Case Review. So there are these deaths which are reviewed according to the SJR structure, and the learning from those reviews is also being considered much more carefully in terms of how the learning from incidents review group interacts with the mortality surveillance group and how we can make this learning more effective. So that is a piece of work that's going on in the organization. And as the report suggests, going forward, we will be able to provide that more joined up information about the learning and also about the kind of data that we want to see in this paper around death. So happy to take questions, clarify, or anything. Thank you.
Ananta, thank you for that comprehensive and helpful report. I've got a question from Tim.
Hi, Ananta. Thank you for that. I'm really just picking up on your point about the real importance of learning from all this. And I just wondered if you could clarify one point, which is, so I can see, picking up, identifying lessons to be learned, having implementation plans, and then it's my question is really a bit about, what the impact and actual benefits of that action plan have been. So kind of closing the loop, and it may just be my ignorance around what the system actually does, but I just wondered if you could comment on that.
Yeah, it's a good question, and I think it's something that we are still trying to refine, Tim. So what happens for most of the actions is that they get devolved to the divisions and to the divisional quality leads, and through the divisional management team meetings and the quality leads work within the divisions, most of the actions are picked up, an action plan produced and reviewed in those DMT, the divisional management team meetings, to close the loop. Some overarching themes, for example, how do we, some of the things that have come out of learning over the last several months is how do we, in older adults, for example, how do we make sure that we have the right pathway between our trust and the acute trust to take care of older adults with both physical and mental health problems? What do we do when we have patients who present with both substance misuse and mental illness, and how are we dealing with it across various services, and what training have we put in place? So that, the big themes that come out then lead to action plans. So, we have, as we know, we are doing a big piece of work around physical health monitoring, for example, about embedding training around dual diagnosis and suicide prevention. So I think that's where the closing the loop happens. And we then look at how many incidents, so what the desired outcome would be, and perhaps which we can present more explicitly based on your question is, so if, for example, if we have done training around dual diagnosis, does it mean that we are able to pick the people up, at an earlier stage rather than them going into repeated crises? What are the number of incidents? What does that mean about, is it a healthy reporting culture, or are there problems? So I think that's a good way of explicitly showing to the board as to how it's having an impact. But that is the process by which our actions are implemented and looked at.
Yeah, thanks, Ananta. That's really helpful. Thank you.
Thank you, Ananta. Sharon.
Thank you. Hello, Ananta. Firstly, I wanted to commend you for the work that you and the team are doing, because I know there's an awful lot of work's gone on to get us to this point, and particularly around the mortality surveillance group, which I have attended, so I know that it's very thorough. I just wanted to pick up in the paper, and it might be the way I've read it. You mentioned about the physical healthcare needs, and the paper at the bottom of page 3 says that there are some emerging themes related to governance, well, systems and processes, which I take to be governance. But it then goes on to say that further consideration will be made as to whether these emerging themes should be included. And I just really wanted some assurance that the physical healthcare issues that were being picked up around governance would be included going forward, because I think that's quite critical that these issues are being picked up, and they should absolutely be included in any scope to shed light on factors that drive disparity in physical healthcare.
Yes, thanks, Sharon. And yes, I can confirm that it will be included going forward. We do recognize and realize that this is a very important thing to get right. And physical healthcare needs come up in various ways, whether they're in serious incidents or complaints or any, the DATXs that we look at. There are, physical healthcare needs featured in everything. And we know, Anita talks a lot about the work that we are trying to do with the system in terms of getting the physical health checks, for example, for patients with either mental illness or learning disabilities or autism. So it is absolutely our, going forward, we are going to be including them in our reviews on a regular basis. And we work very closely with Sarah Alexander, who is part of the Mortality Surveillance Committee and who is, part of the group helping us decide which are the criteria going forward that we will include for structured judgment reviews or mortality case reviews. So physical healthcare features very prominently, so it will be there going forward.
Thanks, Ananta.
Thank you, Sharon. Andy.
Hi, Ananta. Andy Spring, Non-Executive Director. Commend you on the report, Ananta. Thank you very much, and for the work you're doing. Same as Sharon. My question is, how does our current strategy around suicide prevention, align to some of the data and findings that we have in here? Because to me, that there are some stark statistics and data in here around 84% of people are single, separated or divorced. And I just wondered how our current strategy aligns with some of the issues in here, and how we as a board kind of support and assure ourselves that strategy does align with the work and the findings of these reports.
Yes, thanks, Andy. It's a good question. And I think, it is circular thing. So what we have identified in the strategy has come out of the, the themes. One of the ways in which we, look at the strategy when when it's time for a refresh is look at the themes that have emerged from serious incidents and various deaths over the last few, years preceding the strategy, as well as findings from either CQC inspections or system-wide work. So in the strategy, we talk about, of course, prevention, but also, early intervention of risk factors. So when we know there's serious mental illness or, social inequalities, social vulnerabilities, demographic characteristics. So that's the early intervention to look at, holistic work, not just looking at their mental illness, but everything else affecting their lives. And then also postvention. So we know that those the families of those who are bereaved carry a higher risk for suicide themselves. So how are we looking after bereaved families, carers, and the people affected by them? So these are the broad headings of the suicide prevention strategy. So, and when we look at the data that's come out of the suicides that we've looked at, it aligns with looking at those social determinants like, isolation, employment, debt, relationships, the work that's done, whether it is through the community voluntary agencies or our IAP services for early intervention, and also linking in with carer support services. So the strategy flows into our actions, and the learning from the incidents informs the strategy. So that's how they are aligned. At a system level as well, there is a lot of work going on around population health management and inequalities. And when we look at the data coming out of deaths by suicide, we can see some of those factors which are very stark. And in fact, one of the things that we are refining the data collection further. So going forward, there'll be information collected around ethnicity, for example, around deaths by suicide, and what we are doing to address those inequalities, along with, the social isolation, rurality, coastal areas, age, and the services, especially for men, for example. So our trust has focused on how can we help men come forward and talk about their problems, because we know that 3/4 of deaths by suicide occur in men, and traditionally they are less likely to come forward and ask for help, as talking as a whole, compared to women. And how can we encourage early intervention or early help seeking in men, for example? So those are some of the ways in which what's in the strategy aligns with the data that we are getting from deaths by suicide. Thank you.
Thanks, Ananta. It's really pleased to hear that you're championing it across the system as well, and linking with partners to do that. Great, thank you.
Thank you, Andy. A question from Di.
Thanks, Ananta. So yeah, I guess just picking up on Andy's question, I noticed in the report we've got a mix of percentages and actual numbers, haven't we? And I think if I've understood correctly, the sample size here that we're talking about are 33 individuals. So in the grand scheme of things, not a big number, but obviously, any one suicide or attempted suicide is one too many, one might argue. But so I suppose I just wondered about whether or not having absolute numbers rather than percentages might help going forward in terms of helping us to understand the scale of what we're talking about. And given what you were saying there about some of the demographic information in terms of how some of these things intersect, so for example, gender, ethnicity, social circumstances, those sorts of things. And I know we see some of this data a bit differently at Mortality Surveillance Committee, but whether some case studies would actually help us to understand exactly what's going on in some of these situations, and then how we might develop the strategy, I guess, to respond to some of those challenges.
That's an excellent suggestion, and I will take forward the request to give absolute numbers. I mean, nationally, when we see suicide deaths reported, we do have the numbers of numbers of deaths by suicide presented as absolute numbers, but also as percentages, of the population, in the rate being 11%, 7%, etc. So I think, it's useful to stick to anyone and clarify what we are doing. So I will take your point back, and the point about the case studies is very useful. Certainly we'll pick it up at Mortality Surveillance Committee, because we are trying to decide how best to divide the time given to mortality case reviews and maybe a serious incident learning that we can take. So I will take that point back, Di. Thank you.
Thank you, Di. And a final question, I think, from Sarah.
Thank you, and thank you, Ananta, for the report. I'm interested. I suppose it builds on Andy's and Di's point really about some of the statistics on page 4, and I think there's something, in terms of 25% of female nurses or retired nurses. I'd be really interested with registered mental health nurses or registered general nurses. So I think there's something in here at the point that we're building our system people plan.
Yes.
For next year, that we can start to bring some of this work into the staff network groups, both within LPFT and in the wider system as well. We've got a women's network set up now. So I think in terms of not only the suicide strategy, but also in terms of the people plan for the system going forward, I think it'd be. So sorry, I've said question, but it's more sort of a comment in terms of linking all those things up together. So just welcome your thoughts on that, really.
Point very well made, Sarah. And in fact, that's although we've just given these headlines here, the reason why we are just presenting this now is these are the themes that we're going to be picking up and working out in more detail. And as you know, I've been quite closely involved with the setting up of the, thinking behind the staff wellbeing service at system level and in our trust as well. I have a particular interest in the health and well-being of healthcare workers. So I think it's really important. There's a national piece of work as well going on about mental illness and suicide among nurses, female nurses. So it's important to link in suicide prevention, staff well-being, system working, and indeed take learning from a national level as well around this. So yes, it's very much on the cards, but thank you for making that explicit. Very important.
Thank you, Sarah. Thank you, Ananta. A really good paper, some really good points raised in discussion. I was really pleased to note under the dual diagnosis heading that about the fact that we've got some We Are With You staff, integrated into our teams. I think that's a really good step, and really pleased to see that. But thank you very much. We'll move on then to item 5.1, which is the report from the People Committee. I intend to take a short break after this item. No pressure on you at all then, Tim. So over to you. Thanks.
Thank you. Yeah, so Tim Harry, non-exec director and chair of the People Committee. And I'll invite Jay Marshall to make any comment as well. So assuming as ever that the minutes have actually been read, I just wanted to draw out two things. I have some broader comments which I'll save for the annual report, which is later on the agenda. So the two things from this particular set of minutes was, one, the staff story, which was I think one of the most powerful ones I've ever heard, and it was extraordinary really. But it really pulled out and brought to life things around cultural differences and being extremely mindful of that, and factors around retention, which is obviously one of the key issues that the trust faces at the moment. And the other thing really was a little bit of sort of detail, but obviously this is a relatively new committee. One of the things that is being developed is our deep dive schedule, and what we're very keen is that we align that schedule with the board assurance framework and the stories to maximise the value that we get out of those sort of schedules. Anyway, Jane, was there anything you wanted to add on top of that? I'm getting a no, I think.
That was exactly what I was going to say, Tim, about the power of the staff story particularly, and our need to ensure that for all international recruits we appoint, we have that pastoral offer. We recognise cultural differences, we're sensitive to those, and we, as we do with all our staff, we support in the right way and as appropriate to that person or people's needs. But thank you for your summary.
Thank you, Jane. So I guess any comments or questions, Kevin, bearing in mind that you've highlighted we're having a break.
Thanks, Tim. And I can see a comment from Sharon, but if I may go first, just from the minutes of the discussion on the staff story, it's obvious that it was a powerful story with some really important comments, and I wondered what actions we might distill out of that, or what actions the committee distilled out of that, Tim, in order to kind of deal directly with some of the challenges that Dr. Oladusu had.
I'm sure Jane can maybe make some more nuanced comments, but I think the two things from my perspective, and I think from the committee in general, was reinforce the need to do what we are doing in some areas, which is around cultural differences and recognising them and taking those into account, and also some of the factors around retention, which is an area that we are obviously still maturing in, I would say, but it just reinforced the need to do what we kind of are planning on doing, maybe sooner if sort of possible.
Okay, so was the committee then satisfied, Tim, that the strategy, the approach that we've now got in place for international recruits substantively addresses some of the concerns that were brought out in the story, or are there gaps in your view?
I think, yeah, good question. I think it obviously the sequence in the meeting is good, in that we had the story first to highlight some of these issues, and then we picked up on some of the detail around the retention strategy. So I think we were able to sort of feed those into what is a maturing sort of area. So think through that sort of discussion process if there have been gaps, and we sort of pulled them out.
Okay, grateful, thank you. Di.
Yeah, just to come in there, Kevin, because obviously I was at the People Committee, and I think the point's been made already, but maybe just to reinforce that, I think what was really clear from the staff story was just what we assume because of our culture. There are certain expectations in our culture that somebody joining us from a different culture is totally unaware of, and so some of those almost what we take for granted, those simplistic assistance with orientation and just was really came across as being the most valuable, I think, in that space. So and I think that there is some work going on in that. I can we talked about that in the meeting, and I think we can see some developments in that, but I think we can't overestimate that it is some of that. It's those cultural needs, and some obviously, and some clinical needs as well. I mean, one of the points that was made was about the difference in medication prescribing in an African culture. Some of the medication that we use in the UK is not used over there. So there are some, there's some clinical learning that we need to support people with, but in the context of that cultural orientation, I think.
Kevin, can I just sort of build again on what Di just said, which is absolutely right. I slightly hesitated because thinking about the proposal around the International Recruitment Office that we're going to discuss at another meeting, and looking at the scope of what was actually in there, did on particularly on the service seem to pick up all those points that Di talked about, some of those things that you would find, oh my gosh, sort of extraordinary that one makes that assumption, but actually that is a dangerous assumption to make. But even things like what is the taxation system in this country, and therefore what is your net salary as opposed to gross salary. So it appears to be within the scope of what's being proposed in terms of pastoral care, but maybe there's some detail that needs to be challenged.
Thanks, Tim. Thank you, Di. Jane, I think you want to come in.
Thank you. I think we're alive to the challenge of getting the pastoral offer right. Sorry, Jane Marshall, Director of Strategy and People. and I'm supporting everything that Tim and I have just said about being alive to cultural challenges as part of that package that we offer to support our international recruits. I think in terms of gaps, Chair, which was your question, they are the gaps we have, I think, are on the retention side. So we have, for example, stay conversations that are offered, but I think we need to think about how we can more proactively, once we've appointed someone, an international recruit or another member of staff, be proactively supporting them to stay in the organisation through our retention work. Because the power of the staff story that came to the People Committee, as I saw it, was it took an intervention by our medical director in this case, when that person was thinking of leaving the trust, and Nanta Dave, our medical director, was able to have a supportive conversation and helped that person want to stay at LPFT. So I think it's about the gap for me is systematising that approach to helping people to have the conversations about staying at LPFT, rather than it just being by chance that we pick up that someone is thinking of leaving. I hope that makes sense, Chair.
Yeah, Jane,
and if I didn't describe that adequately, then I apologise.
No, that does make sense. And I'm conscious that we're coming back to the issue of international recruitment when the board meets in private after the public meeting. My final comment is this, that when we're looking at the kind of pastoral care that we put together, one of the lessons I take out of this staff story, and I think Andy's alluded to it in chat, is that we need to be culturally sensitive when we put that pastoral care together, and not assume that we know what the packages of pastoral care need to be. So we'll come on, I'm sure we'll come on and focus on that, but that seems to me to be a really important point arising from these minutes. I do forgive me, Sharon, I missed the fact that you had a comment, but I'll go to Ananta first, if I may, and then a comment from Sharon.
Yeah, thank you, Kevin. Ananta Dave here, Medical Director. And I just want to say that, as we go forward and look at how we support international staff, it's important to learn. I think we have people here. I mean, because the Medical Directorate has had people, trainees especially, come in international role from international backgrounds. We need to, incorporate that learning and that feedback into our current recruitment offers. So as we develop that package, I think almost it's like having a peer mentor or peer worker to inform us of the work. And I think the points made by Dr. Oladosu were so salient and resonate so much with me after all these years that, worth remembering them as we work with our international, pastoral care lead, etc. Thank you.
Thank you, Anand. Thank you very much, Ananta. Good, really, really good points. I've got Sharon, and then a further comment from Di. Sharon.
Thank you. I just wanted to pick up, Tim, the issue of equality impact assessments, which is in your highlight report. I think that as a board of directors, we need to be aware that currently there's limited assurance on equality impact assessments being undertaken on all key decisions and policies. And I think in the People Committee, there was, out of a 7-month audit, something like out of 111 board papers, only 39 made reference to equality impact assessment, which is a legal requirement, but also it's nothing new for us as an NHS. So I wanted to raise that we need to get the basics right, and I know there are plans in place in the People Committee to start doing that work, but I thought it was important that our board members are aware of the position.
Thank you, Sharon.
Yeah,
Tim.
thank you, Sharon. Absolutely right, and thank you for raising that one.
Di.
So just to kind of further reflect, I think. Obviously, quite rightly, we focused very much our conversations on supporting and welcoming colleagues from other countries, in this case African countries. I think it's a challenge to us actually as an organisation and as a board in terms of what we stand for and our values as an organisation, because whilst obviously these people are joining us, those countries from which they are joining us have an even more depleted specialist mental health workforce than we do. And so, you know, and they will still have networks in their country. So for me, I think there's a question that we haven't yet addressed, which is about how we support some of that learning to go back into those countries that could well be very adversely affected, if we're honest, by the fact that they are losing colleagues to come and work for us here. And I think we would have a position on that as an organisation that is very committed to our people. So I would just put that out there as a challenge to us as an organisation.
I think that's it's a really powerful point, that, Di, and I think that that's a what's the right word, a difficulty that I certainly wrestle with as chair, and I think it challenges us as a board, and it's right that it should, and I think we're probably steering the right course at the moment, but it's right that we should continue to be challenged by the ethics of what we're doing. It's difficult.
And I think continued dialogue with our international colleagues as they join us about what that payback, if you like, might look like would be welcome. Yeah,
I mean, I think there's a bit of thinking that as a board we could do about what the payback is, and I've had, just as a kind of en passant, as it were, had some conversations with Lincoln University about linking and with you as in terms of linking with some of the overseas work that universities do, and I think that's one way into supporting the communities that we're drawing these valuable staff from, but it is a conundrum, a difficult one. Thank you, and thank you very much, Tim. That's been a really useful discussion off the back of your report, so thank you very much. I mentioned that we would take a short break. I certainly need a cup of tea, and colleagues may feel the same. It's now 10:27. Can we reconvene, please, at 10:40? Great stuff. Thank you.
Thanks.
Right, I think we're all back, so let us restart. We are, I think, on item 6.1, which is the integrated performance report. Mark, do you want to do your usual circus master routine and lead us through this?
Excellent, thanks Kevin. So good morning everyone, I'm Mark Platts, I'm the Director of Finance and Information, and I just wanted to present the new revised format for our integrated performance report. So I'm just going to do a really quick introduction to the report and how we're going to shape it moving forward, and then going to hand over to Chris, Anita, Jane, and then back to myself to close as part of the presentation. So the report is quite different to previous reports really. We've really kind of built on a lot of feedback and comments to make sure that the report provides more insight around the challenges facing the organisation and, more importantly, what we're doing about them. So in terms of the report, there's a lot more sort of narrative in there and updates really. I just wanted to thank our business intelligence team and Chris and everyone involved in the development of this. It's been a really good effort to get to this point, and I think the important point to note at the start of this is this report has now been built around a much longer, wider process where there's many stages of report and challenge around data and performance to get to what we're seeing within this report now. So it's not been developed as a report in its own right, it's been developed as a suite of reports that are actively used throughout the service. So I'm going to stop there and hand over straight to Chris, if that's all right, to take us through the operational updates. Thank you.
Thanks, Mark. Yep, Chris Higgins, Director of Operations. So as you see this time, the look of the operational section is quite different. What I've provided more of an exec analysis of what's going off in the operational services, and then you'll see where there's particular performance issues. They've been explained by the services with the performance improvement plans linked in. What we'll just say really is that on the whole, when you look at performance across the organisation, the services continue to perform pretty well really, considering the operating context that we're working in. You know, we've all seen the pressures of COVID. That has an impact on the number of people presenting for services. We're seeing that. I think the prolonged nature of the pandemic is starting to, we're seeing the results of that in terms of referrals across services. Also, our staff aren't immune to the effects of COVID, both through ill health or isolation. So with COVID on top of underlying vacancies in some of the teams, that pressure on teams is quite high. That's led to a number of short-term challenges, which we've talked about before here and in other committees, on particular services where they're struggling to meet demand for staff availability reasons more than anything. And we've had to put business continuity arrangements in place to make sure that those services continue to perform and meet the needs of people who are presenting in a safe way. There are some medium to longer term issues, some of which the board's already cited on from previous reports, and really the headlines there that I think are worth drawing out are our Children and Young People's Services, CAMS, where we're seeing demand outstripping capacity of the service. Work's being done to try to improve and maximise productivity with the resources that we've got, and there has been some investment to try to improve capacity, but even with all those things combined, we still believe there's a shortfall in meeting the demand for people coming through and presenting for support. And so we're working with local commissioners on that. There's been a detailed report, and we're working up a trajectory for improvement and really quantifying what we think is needed to be able to bridge that gap. And so there's a good comprehensive and collaborative piece of work being done around that's going through the Mental Health, Learning Disability and Autism Partnership Board, and will also come through this group into the board to set out that trajectory for improvement. The other one is autism, what waits for autism diagnosis. Again, demand outstripping capacity. You can see some of the figures in the report there. That's a significant rise in demand over the last few years. There are some of the solution is longer term review of the whole pathway from right through childhood through to adults. But the part that LPFT is responsible, which is adult autism diagnosis, we're seeing significant waiting times to be able to access those services and get a diagnosis, and then onto any support that comes after that. So what I would say on that, we've got a paper put together. We've had some progress in the last couple of weeks, and there is actually a meeting at 4:30 this afternoon with LPFT and our clinical commissioning group colleagues to try to look at a solution to be able to put some capacity into those services and meet that demand. But in terms of managing expectations, because of the level of backlog, it's likely to be a 1 to 2 year recovery plan to be able to get us back on track, to be able to get people in post trained up and be able to see that number of people and offer appropriate support. So I'll provide a bit more detail on that next month. Good news in terms of the waiting times for eating disorders. Whilst we've been struggling with that, we've had some investment for our adult eating disorder service, and recruitment has been successful, and we're expecting that waits will come back on track in the next few months. So we'll be back within our commission waiting times. And the other one just to flag is IAPT. You'll see from the report there's a couple of areas where IAPT performance is down or below target. We're seeing an increasing number of people coming through and presenting for IAPT services. That's good and it's bad. It's obviously coming through in a pace that makes it difficult to keep up with demand, but we do want to see more people, and we expect to see more people in IAPT services anyway, and as a result of COVID. So it's not unexpected is that demand, but meeting capacity, bringing capacity to align to that demand is just proving tricky. The other one for us to watch for as a board is recovery rates for IAPT. It's currently below target. We are linking that currently to the fact that we've got a number of new trainees in the service, and it takes a while for them to get up to speed and performing at an optimum level. However, just a cautionary note around the move to digital working. We know we've really embraced that, and that brings a lot of benefits in terms of choice and access. But also we just need to do that piece of work to make sure that it's delivering the same or better outcomes for patients, and we've just got to make a cautionary note on that. But so as restrictions ease, we'll be able to test out some of those hypotheses and see where we get with that. But at the moment, we're expecting as those trainees get up to speed, performance will improve. Just to finish off, really, I mean, there's lots going off, and I know it's been covered elsewhere on the agenda, but just to flag, despite the pressures that we're under, the teams have really pulled it out the bag with the assessment centre. Such a short space of time to get that up and running and enhance the service offer, both for our patient service users, but also really helping other system partners, our colleagues in ULHT, the acute provider, and EMAS and the like. It should, even if there's a little bit of pressure, it helps everybody in the system. So that's a really good move. And again, the nightlight cafes that are being expanded across the county, you know, really brilliant piece of work to get that provision in people's local communities exactly where it needs to be. Again, working with our community and voluntary services sector to set them up at pace has been brilliant, and yeah, a great bit of collaboration. So lots to do, lots of pressures, but much to be proud of, I would say. So happy to take any questions.
Thank you, Chris. Comment from Anita.
Thank you, and it's, I mean, Chris knows this really, but it's more for other board colleagues. So we have bi-monthly engagement meetings with the CQC, and at the last one there was kind of presentation from the adult community division, but there was a specific focus around the CAMHS weights, and they did ask, you know, if we could supply further details. So actually we met, and Kevin and Sarah were part of that meeting, but Eve Baird, the Associate Director for the Specialist Division, came and presented the paper that Sustainability Committee had already seen about the CAMHS weights. She was really honest and said, you know, due to some of the issues with Omicron and high levels of staff kind of absences, it had potentially gone a little bit awry, but there was certainly a kind of feeling from the CQC, and they were very clear to say, you know, we can see that you know your issues and you're not hiding your issues, and actually there's really clear plans in place to address them. So they were kind of really grateful for that. Nobody at any point is saying that, you know, and trying to cover up the issue. We've been very upfront about it, and they kind of welcomed that and the real plans to address that. So I think it was I just needed to add that into Chris's point, really.
I think that's an important point, Anita, and one of the things that it demonstrated, I thought that Eve played an absolute blinder in, you know, kind of presenting where we are and where we're going, and it just demonstrated for me that the absolute importance of demonstrating that kind of grip on the detail of what's going off, as Chris put it, and that, you know, that worked really well, and that and openness did as well. Di.
Thanks, Kevin. And thanks, Mark and Chris. I thought the report was much improved, and I think you know, it's much clearer in terms of you know, focusing our attention where it needs to be focused. I just wanted to ask about, we've got a couple of things going on, which is a bit different, I think, for us. So we've got 4 patients out of area, which is not something that we've, you know, that we've had to sort of look to in previous meetings. And the reason for that is because I think the Wolds is closed currently. And again, if you track that back, that's because of the staffing issues and COVID related. And then we've got the long-term condition pathways with an extreme low point. And when I looked back at the organisational risk register and risk 125, which is the risk that seems to be relating to staffing issues according, you know, because of COVID, I just wonder whether we're articulating that risk appropriately at the minute, given these 2 particular sets of circumstances, and whether we need to have another look at that to reflect what, you know, what these issues are telling us, really.
Thanks, Di. Chris.
Yeah, thank you, Kevin. Can I just come back on that? So absolutely, yeah, I think it was flagged by Kevin on the risk register item, is that the reason that risk 155 is increased is because the likelihood has increased, because we're seeing that across a number of services, and in particular on the, just to pick up a point about out of area placements, it's something that we've closely scrutinised as a board and as an exec team for some time, and continue to do so. That I'm confident that the people out currently are because of the temporary closure of the wards, and that was reopened this week as a phased return. But just to reassure board members, we wouldn't just automatically transfer those patients back automatically if they've got an ongoing care package and treatment plan. So we'll make sure it's individually tailored, but we should see that number coming back down to 0 in the next kind of few weeks or a couple of months.
Thanks, Chris. Sharon, apologies, I leapfrogged you earlier unintentionally.
No, that's fine, thank you. It's probably a question to Anita, really. It's just to explore a bit more, as an organisation, how are we, given the long waiting lists, I was thinking particularly of CAMS, but all of them, how are we monitoring and mitigating the risk of harm to people on the waiting lists? Is there anything that's happening in addition to our usual processes?
Yes, so, and actually we've been having this ongoing discussion for the last few weeks, myself and Chris, and kind of the crossover in the teams. So we had a very focused session on each of the operating services with waiting lists. I've done a really detailed standard operating procedure. They've really updated those, so we actually monitor and how we monitor people on the waiting list, how we review risk, how we kind of monitor change in presentation. And it is a really, and Chris articulates it very much better than I do, but it is really a difficult balancing act, because if we can put a lot of clinical care into people on a waiting list, then we wouldn't have them on a waiting list, we'd be offering. But the work we're doing at the moment is Kay Gamble, the new patient experience lead, is working closely with the operational services around the standard operating procedures, just to see if there's some cross-divisional learning, if we're doing exactly what we said we'd do as part of those, that we're reviewing the risks. And actually waiting lists shouldn't be on, risks shouldn't be on the amount of time they're on the list. People's risks change and vary and go up and down, and that is something that is really embedded as part of what ops are doing as part of their everyday kind of work. But we've brought the quality and safety team in to have an additional level of assurance and overview.
Yeah, thank you. I just think that needs to be well cited at or subcommittee level, so that we can demonstrate as an organisation that we are ensuring we do no harm in terms of the waiting lists.
Yeah, and I think that and what I can ask is for a report to go to PSEG of the work that's happening now, and then it get reported by exception through to quality committee, so that the whole pathway is cited. Yeah, definitely.
Thanks.
You're welcome.
Thank you, Sharon. Philip.
Yes, thank you. Philip Jackson, Non-Executive Director. First of all, thank you for a very clear report, and I think the revised format is a significant improvement, so thank you for that. It was just a question around the waiting times for the adult autism diagnostic assessments. In the executive analysis, there's a paragraph describing the issues there, but unless I've missed it, and apologies if I have, I didn't see any data later on, any graphs or anything describing the problem. Now I'm not sure whether or not that would help to inform the issue to us as non-exec directors, but I just didn't pick up anything in there later on in the report giving us more information.
Shall I come back onto that, Philip? Just say, yeah, I think because it's been reported previously, I was just giving an update in exec summary, but I think, yeah, wherever I'm making comment in that exec analysis, I will make sure that we've got some data in below to back that up in future reports. So yes, yeah, good point, and I'll make sure we pull that in for future reference.
Yeah, thank you. That'll be helpful. Thanks very much.
Andy.
Hi. Thanks, Mark. Thanks, Chris. I've asked questions in the past about a number of indicators that are no longer in the report. Examples of that would be supervision, percentages, number of, if you like, medicine errors, and also the kind of, if you like, indicators that would tell us about staff well-being, violence, aggression, harassment. So those indicators are ones that I think Chris has said in the past they would tell us whether the service was under pressure and the intensity of things. So I just wondered where those things are now being covered and how we as a board would then be cited on those indicators to say, because I recognise, Anita, in terms of the medicine errors, you've told me the vast majority of them are minor ones, just how we're cited on when there's anything that might cause concern to the board, and therefore to assure the board that these indicators are still being looked at in a way that will help us manage the organisation.
So I'm happy to pick some of that up. And
yeah, thank you, Anita.
Andy. Just in terms of that, can I just shut my door? I do apologise. My dog walker's just arrived and all hell has broken loose in Sleaford. In terms of that, we know we have a lot of work to do on the quality section of this IPR. So Chris has focused very much this month on the operational service, and I'm working with Mark. We know we do have some issue on being able to get the data in a format that really is of use to the board. So Mark and myself and Lucy Kent, the Associate Director of Quality, are working with the BI team to look at how the quality metrics can truly become integrated to Chris's report. So they haven't gone away. It's not something, it really is work in progress. But no, I absolutely agree. So it's important that we add it in. It most certainly hasn't gone away, and I'm really conscious at the moment the quality section kind of focuses on safe staffing, and that's not an integrated report, so it very much is on my to-do list. Yeah, thank you.
Thank you, Anita. Thank you, Anita. Chris, do you want to add?
Yeah, so just one of the disadvantages of the previous report was that there was quite a prescribed set of metrics that drew the board's attention to certain areas and not to others. And what that meant is, I mean, as an organisation, because of the number of services we've got hundreds of metrics across, you know, hundreds of services kind of thing. So it's about what the new system does through operational escalation and through the objective challenge through BI, is we're able to highlight issues that might not previously have come to the board's attention, services that probably weren't there. So what we'll see each month, hopefully, is changing metrics coming through in that operational section, divisional section, which are the key issues of the day that have been born out of operational escalation, say, and BI scrutiny. So hopefully we'll bring the right issues to the attention of the board, but that should be then covered off through things like supervision appraisal, through the quality route, all be picked up, and hopefully through PSEG and others will be able to monitor through there as a kind of an extra layer of assurance.
Thanks, Chris. Thank you, Andy. Jane.
Thank you, Chair. Jane Marshall, Director of Strategy, People and Partnerships. On the workforce element, Andy, you will know because you were a member of the People Committee, we've developed a comprehensive dashboard for all of our workforce indicators, our people indicators, and some of those will be reported through this integrated performance report, but the rest will be reported through to the people committee. So just to give that assurance that we won't have lost any of the granularity that we previously had. Thank you, Chair.
Thanks, Jane. Before we move on then to the people section of the IPR, a couple of questions from me, Chris, if that's all right. And they're both on the autism diagnostic assessments. Do we have any sense of what is driving what is a really significant increase in referrals over 2 years? Do we have any understanding of the cause behind that?
So I think there's probably what we suspect is three contributing factors. One is public media has increased, and people are identifying as potentially having autism later in life. We've seen celebrities being able to come forward and describe it. So I think that's having an impact where people are recognising actually that I might be able to relate to that and want to get that checked out. There's also, we know that there's evidence to suggest that people with autism are impacted more severely at times or greatly by the COVID pandemic and the change and disruption to people's lives. So we think that that's having a compounding factor. But one of the other things is the pathway. LPFT's data and responsibility here is for adults. If ideally children, well, autism is diagnosed at a young age, it's developmental order and should be diagnosed at a young age, so reasonable adjustments can be made to people's lives. We don't believe that the other end of the pathway, the child in the pathway, is comprehensive enough. Maybe we know we've got gaps in terms of that provision, and that means that those young people are progressing to adulthood and coming to our services. So alongside doing some capacity work, we need to look, we're doing a piece of work with local commissioners and partners to look at the whole pathway, because that's the answer, is we need to see people at the appropriate young age, and then there'll be less assessments needed at adulthood. But there's a whole piece of work to do on that to understand that properly.
I'm grateful. Thanks, Chris. That's really helpful. And my other comment was just how much I welcome the new format of the report. I mean, that doesn't just apply to your section, it applies across the piece. And, you know, my mantra has always been less, fewer data, more insight. And this really does get us to that sort of position. So I'm really grateful for that. Do you want to move on then, Mark, to the people section?
I didn't necessarily, just wanted to nip in for a quick point on autism.
Oh, yeah. Sorry, and then I've got a comment from Sarah. Yes, sorry. I'm not doing very well today at spotting.
No, you're fine. You're fine. Chris is covered off pretty much, and I'll make sure it's covered in the CEO report next time. So thank you. We can move on.
Thanks, Sarah. Mark.
Excellent, thanks, Kevin. So yeah, I think we're picking up. You know, we can refine the report as we go along, but the key bit is the process that we've got on the report means that we're bringing the highlights and exceptions to the board for discussion, really. So that kind of leads me nicely on to the people section then, Jane. If I can hand over to you to give us an update, thank you.
Thank you, Mark. Jane Marshall, Director of Strategy, People and Partnerships. So page 16 of this report, and I too welcome the brevity and the ability to bring in far more analysis of our position on the people agenda, backed up by the detail which will go through to the people committee on a regular basis through the dashboard that I mentioned earlier. So page 16 of this report has a narrative at the top that links to our strategic objective as an organisation of being a model employer. You'll see, and I think this picks up some of your comment, Andy Spring, on the Health and Wellbeing Index. Overall, on the People Promise, we are scoring very well when we benchmark ourselves across different organisations, different mental health organisations. But you'll see from that report that within that we have a couple of hotspot areas at the top of page 16 which we are paying attention to. Those relate to an overall single oversight framework of a health and wellbeing index that includes a number of indicators, including the two highlighted there, where we know we've got work to do. So those are staff who report experiencing bullying and harassment, abuse at work, and also representation within our workforce of people of a non-white heritage. So we're actively working on doing all that we can to address those challenges that we continue to have, and those are reported again through to our People Committee, which Tim Harry, our Non-Executive Director, spoke about earlier. At the bottom of page 16, and this really triangulates with the comments Chris was making, we have our staff retention rate, which is measured by staff turnover. You'll see from that statistical process control chart that we are monitoring an increase in staff turnover rates, which is quite exceptional for us. We haven't seen that previously in the historical trend of our data. And the commentary on page 17 talks about what we are doing to address that increase. I think I'd like to say at this point, some turnover, staff turnover is completely natural to be expected as staff progress their careers and move on in some cases, but equally it does need our attention as an organisation, and we're doing that through a newly developed retention and attraction strategy and plan, which the People Committee approved at its last meeting. And just finally from me, again at the bottom of page 17, we have our sickness absence as recorded, and again as Chris and Mark have both mentioned, we have seen the impact of the current situation in terms of staff absence, and that's reflected here. We do think the January data, when they come through to board, will show a further increase, but we're monitoring that on a daily basis through our situation reports. And that's all I had, other than we've got some detail at divisional level on pages 18 and 19 about our vacancy rates, Chair, which I know have been a particular point of attention for the board. Happy to take any questions.
Thank you, Jane. Really helpful report covering the things that we need it to cover and with the right kind of commentary. I'm grateful. I don't see any questions or comments from colleagues. Just a question which I'm not expecting you to have an immediate answer to, Jane, but it's around turnover. Do we have a sense, either from benchmarking with other trusts or more generally, what a kind of healthy turnover rate is?
We don't have a current position. Our target turnover rate in the past, as you'll see from the report, has been a benchmark target of 10 to 14%. But I think it's worth us, given the current position and everything that's changed over time, revisiting that and doing some further benchmarking work to clarify that target. And as I said, there will be a natural level of turnover that is absolutely right for people. So we need to bring that into refresh it, I guess, and bring it back to the People Committee. And
it's quite a complex metric potentially, isn't it, that's informed not only by benchmarking with other organisations, but our own age profile, for example, which needs to, read into that too. Okay, that's helpful, thank you. I don't see any questions or comments, so I think Mark, it's back to you.
Excellent, thanks, Kevin. So yeah, I'll just close giving a few highlights from the sustainability section. So overall, we are continuing to meet our financial targets both year to date, and we're forecasting to hit them as well, which is really positive. So one thing that we'll sort of say included within this month 9 position is we did take the strategic decision to offer incentives to our staff who are working over the festive period. So I think that the benefits of that was we've sort of come out of what was already a challenging winter position going into it in a much better stable position than we would have done had we not offered that. And I think we saw that playing out across the system as well. So whilst it was quite an expensive thing to do, I think it helped us maintain a high quality of service. So I think from a financial viewpoint, it was worth it really. In terms of our cash balance, so you'll see that we do currently still have a much higher cash balance than we were planning, and that's pretty much driven by our plan, including is to be much further ahead in terms of our eradication of dormitory scheme over in Boston. So that scheme has kind of been delayed a little bit, and we continue to work with NHS England and improving our regulators to push forward on that scheme. We're still planning to deliver it in time with the mandated timeframe of the 31st of March, but we're just working with them to readjust phasing and pull that forward. So that variance, although big numbers, it is pretty much driven by one scheme over in Boston. So the focus of attention now is firmly on getting us ready for next financial year. So we're working with system partners to make sure that we go into next year in as stable and sustainable position as we can, and a big part of that will be making sure that we get our system capital plans up to date and accurate, really, so that we can all afford the schemes that we want to. So obviously coming next year we will be back onto what is a traditional kind of contracting agreement with funding and different bits and bobs like that, so we won't be operating on a COVID funding regime. So with that will come the need for us to start to reconsider how we make cost improvements and how we make efficiencies within our service. So it's going to be a very fine balance over the next couple of months, planning for next year, to make sure that we can maintain the quality but also maintain that financial stability in what is going to be a very financially strapped year. So happy to take any questions on the sustainability element, Kevin, but on that I'll end the report, and if there is any additional feedback, any kind of possible revision or refinement of the report, just let me know and we can pass it on to the team. Thank you.
I'm grateful. Thank you, Mark. It's as ever a comprehensive and informative report. Note what you say about the unusual movements that you've reported. I'm not sure. I don't see any questions or comments from colleagues. Yes, I do. I've got a comment from Tim.
Hi, thanks, Kevin. Mark, thanks very much for the report. And just to echo everybody else's comments about, it draws attention to the areas we need to have a discussion about. So slightly counterintuitive to all that and Kevin's comments about insights versus data. I still wonder on the trust board, the trust level metrics, whether some sort of summary of numbers out of exception and the trend with time is just a one way, and obviously it's there are dangers in it, but some sort of indication in terms of the health of the trust in respect of those. Just a suggestion, that's all.
Yeah, that's fine, thanks Tim. We can build that in, and I can do a bit of an exec summary for that section of the report as well. So thank you.
Yeah, I think that's a helpful suggestion, Mark. I think this report is going to evolve, isn't it? This isn't the done deal, and I think that that kind of tweaking is going to make it more valuable. Great stuff. I don't see any other questions or comments. So first of all, thank you, Mark, for guiding us through the IPR. I think that's been a really good discussion around some tricky issues in terms of performance and people in particular. Really welcome and echo the comments of colleagues around the format of this. It will, as I say, I'm sure it will evolve, but I think it gives us a much better sense as a board around what the exec team are, how they're responding to the movements in the metrics, and I think that's the key issue, and focuses in really well on where the key action points are. So thank you, good stuff. Let's move on then, shall we, to item 7.1, Tim, which is the annual report of the People Committee.
Thanks, Kevin. So I just wanted to make a sort of couple of points around this. So this is obviously here for approval and then onward presentation to the Council of Governors. But it does highlight this is the first annual report, and is a summary in effect of 5 meetings that have been held. And I really wanted to thank and point out the work as a new committee that the officers, fellow Neds, and Peter as Trust Secretary have done to get it to the point where it actually is. I'll make a sort of further comment on that maybe at the end. So on the assumption everybody's read it, it's got the things you'd expect in an annual report, highlights around the annual people strategy, I just want to make a couple of general comments. One is the breadth of subject matter that the People Committee covers and the number of challenges within that. And I know that's true for every sort of committee, but you know, there are a number of key areas of risk for the organisation in here that the People Committee covers, particularly around retention, recruitment, the EDI agenda and the health and well-being. I think that there is still further work to do around the maturity and development of the People Committee moving forwards, and I've had some useful suggestions from colleagues around that. I'm working with Jane and Peter in particular in terms of how maybe we format the meeting moving forward. So I hope that maybe come this time next year when the second annual report is presented, one can give a further update around how the committee is hopefully being even more effective in terms of making sure that it focuses on the right things and puts the right amount of time against the key things. So obviously, as before asked, Jane if she would like to sort of comment on the annual report, but I hope it's fairly self-explanatory.
Thank you, Tim. Jane, is there anything you want to add?
Thank you for the opportunity, but no, thank you. I think it reflects the work of the committee so far, and I look forward to the next report, as Tim does.
Thank you, Jane. Any questions or comments for Tim? Tim, it is a self-explanatory, appropriately detailed and helpful report. Thank you. Which speaks, you know, well for itself. I don't see any questions or comments, so the board receives your report. Thank you very much.
Thank you.
The next item, I think, Peter, is yours.
Yes, it is. Thank you, Chair. It's Peter Howie, I'm the Trust Secretary. This item is a paper that sums up the outcome from the last joint board meeting where the board and the council meet together. This was a meeting we held to sort of explore and confirm the way in which our governors undertake their two key legal duties of holding to account and representing the public. This paper sort of summarises what we agreed out of that meeting and really takes forward the key elements, one of which is a new performance assurance report, which will go to the Council of Governors for the first time next week. The other is taking the governor membership strategy, which the board approved in December, converting that into the plan and delivering many of the elements of the governor's responsibility. That was done through the governor's own representation committee meeting in December and was successfully produced. And also to look at the governor's training needs. The training need analysis goes to the Council of Governors meeting next week, has got a couple of recommendations in it that will be dealt with there. And just to note, we're proposing the lead and deputy lead governor join the training planning group to make sure we have got representation of the input for that training. I think the day went well. We've got what we wanted to achieve, and this paper just sums up where we're at.
Thank you, Peter. And you require from the board to approve the outcomes of that meeting, is that right?
Yeah, basically to approve that the board is happy that those are the outcomes, because we'll obviously be taking them to the Council of Governors, and because the governor and membership strategy is there, it will be for the board to approve. Okay, understood. Any questions or comments from Peter? If not, are we happy for him to proceed as he's proposing? Tim, sorry, you've got a comment.
Yeah, sorry, Kevin. It's actually not on this paper. It's on the previous one. As Sharon has highlighted, we'd actually need to approve it rather than note and receive. Yeah. But I see in the comments that I've only seen approval so far.
Yeah, sorry, I was going to come back to that. So
sorry, yeah.
No, that's quite all right. Don't worry. I think people are happy, Peter, for you to proceed as you're proposed. And as Tim has said, you know, technically I should have invited the board to approve Tim's report. There has been plenty of traffic in chat that unfortunately isn't on the public record, so I just need to confirm that that report was approved by the board. Peter, I think the floor then is still yours.
Yeah, this is the forthcoming meeting schedule that we produced just to help everybody make sure diaries are all confirmed and tied up. Only significant point of note in all of this is this includes the rescheduled dates that we agreed, and as things currently stand with the current board and meeting risk assessments, all of these meetings remain virtual meetings on Microsoft Teams.
Thank you, Peter. Any questions or comments? No. If not, then I think, Sarah, the final substantive item is yours.
Thank you, Kevin. Sarah Connery, Chief Executive here at the Trust. So this paper on our 3-year green plan is a bit of a way to close a loop, really. It's here for information. So you remember before Christmas last year, we had a draft come to the board. It was a bit rough and ready from a presentational point of view, and it gave chance for the board to sort of put in their comments and amendments before submission on the 14th of January, which was completed. So we have submitted to NHSEI our green plan. We haven't had any feedback as yet. For assurance, I just wanted to say we did pick up the feedback. For example, Sharon, we talked about blister packs, single-use plastics in sort of medicines procurement. We've made sure that that's reflected in the document. I just want to finish by saying a massive thank you to Jo and her comms team for getting it into what I think is quite a vibrant and accessible document. That's just my view. But the important thing is we crack on now and actually deliver this. So just to remind colleagues that the delivery will be reported through the Sustainability Committee and then up to the board. So happy to take any comments or questions.
Thank you, Sarah. Tim.
Thank you. And I really enjoyed reading this, actually, and it's such an important area and fully endorsed that I think the presentation was really good. I've got one sort of question, and I guess it really relates to what may be shared with the Sustainability Committee on its sort of progress. It's really around risks and risk register, and so, you know, what are the challenge? What is going to stop us actually achieving this green plan? It's a great plan, but we know it's not going to be easy to implement. So maybe understanding a little bit more about that at the sustainability would be really helpful.
I think that's an excellent point, and we'll probably touch on it later when we're talking about Norton Lee in private session. You know, the right thing to do is rarely the easy thing to do, and a big constraint will be capital allocations in order to make sure that our buildings are compliant with net zero carbon. So it's a really good point. We'll make sure that that gets picked up in our smart plan reporting. Thank you.
No, thank you.
Thanks, Tim. And as you say, Sarah, there is a tension in all of this between what we would like to do and what we're being encouraged to do, and what our funding envelopes will allow us to do. But I think it's a key role for the board in helping us to navigate that tension. And we'll come on and talk about it later when we come to Norton Lee. I thought this was a really well presented, clear, easy and quite enjoyable to read plan, Sarah, so really grateful. Thank you.
I'll feed that back to the team. Thank you.
I've not been notified of any other business. Peter, I don't know whether anyone's mentioned anything to you.
No, I've got no matters of any other business. The only point, Kevin, under self-certification, if nobody else has got any.
No.
Okay, so self-certification point, because it is one of the national expectations, because we have got out of area patients, the board should just note and record, and Di flagged it earlier, that we, if we are required to report on national standards at the end of the year in our self-certification, we might have to explain that and why, although we understand the reason.
Okay, thank you, Peter. That brings us pretty much to a conclusion. That's been, I think, a really positive meeting with some really good discussions around some tricky and important issues. Really welcome the representation of the integrated performance report in particular. I think that's showing some really great progress. So the last thing for me to say is to thank colleagues for their contribution this morning, which I think has been, it's been really, really good, high quality set of discussions. Now we should reconvene in private board to deal with those matters that can't be dealt with in public. It's now, according to my clock, 11:24. Are people happy to reconvene at 11:30? Excellent. Thank you very much, everybody.
Thank you.